All right, thanks. Actually, that was a really good segue into what people that don't have access to those types of devices are doing. So I'm glad you kind of went through a lot of the sort of procedural logistics because it's all applicable to PMEG. But this is kind of the option for a lot of us. So thanks for letting me speak. Some disclosures there. So when we're talking about complex aortic pathology, again, we sort of alluded to this. Yeah.
Can we get back just throwing the slides up?
Oh, sorry, they're in front of me. I didn't realize they're not up there. Okay. That's me for real. Okay. Here's my disclosures. We were actually just trying to hide all the disclosures from you. So in the US, as we kind of alluded to, there's limited options for the treatment of anything more complex than a simple infrarenal or thoracic aneurysm. And ZFen is the only FDA-approved device that has any sort of branches or fenestrations. And actually, in reality, it's made for infrarenal juxtarenal aneurysms, right? The IFU for ZFen is actually a 4 millimeter neck. So this is not really supposed to be used for no-neck aneurysms and what it's being used for, which is, pararenal, even thoracos. There's a lot of limitations to the design of ZFen. You can only use 3 fenestrations, only 2 of which can really be stented properly unless you're talking about a scallop. So there's a lot of pathology that can't be treated with what we have available. As Dr. Schneider talked about, there's PSIDEs at several sites, but most of us don't have access, and there's a lot of devices in trial, which we talked about. But really right now, what are we doing? We're doing chimneys, we're doing in situ laser, which we're gonna hear a little bit about, and then physician modified grafts, which we're gonna talk about. So what is a PMEG? Really what we're doing is we're creating custom devices ourselves rather than having a company manufacture them for us. We're opening the device, measuring, creating fenestrations, creating branches, and then trying to safely repackage and deliver the device into the patient for branches and fens. It's a good option for all sorts of things. I mean, really, this is it's a do-it-all type procedure because you can make the graft into whatever you want, right? So pararenal, paravisceral. I would say a large proportion of my PMEG practice is revision of prior failed infrarenal grafts with type 1As where there's not really a solution for that. And then in the arch, although I have not been bold enough to do arch PMEGs just yet myself, I'll let someone else speak to that. What it is not is a replacement for manufactured devices once they become available. I think it's definitely going to be a secondary choice, right? There's inherent issues with creating a device yourself and tinkering with it. There are a lot of risks associated with the modification. The durability is very unknown, right? We're burning holes in these devices that aren't supposed to have holes in them, and so we don't know what's going to happen long term. And there's even a potential for medical legal exposure and liability. It's unclear what the sort of lawyers think about all these kinds of things. So that being said, let's talk about how we do it and encourage you all to do the same. So again, similar to with custom devices, the plan is the case, right? So you got to identify where you're going to land the device, both proximally and distally. You're going to decide on what number of holes you're going to make. You're going to decide whether they're going to be fenestrations or branches, and I use very similar criteria, not surprisingly, since I trained with Dr. Schneider about where to put fens and where to put branches in what scenarios. I think that there's some important things here. Again, you can kind of design this however you want, but when you're designing it, you really need to make sure to leave room at either end of the graft for extension later. So one of the issues with ZFen, for example, is your fenestrations are going to be like 2 centimeters from the top of the graft. So if you have to extend up into a thoraco, there's nowhere to seal, and you're almost guaranteed to get a type 3 endoleak. So I always leave 4 to 5 centimeters at the top of my grafts to allow sealing of an additional piece if you want to extend upwards, and similarly distally. Again, it's similar planning to any repair, but you have basically unlimited options with some caveats. So how do I do it? First thing you got to do is choose a graft. I tend to use Cook devices for this, or I exclusively use Cook devices, Alpha, TX2, and I've actually modified a number of ZFens as well. People are using the Terumo device, which I don't really have a lot of experience with, but I'd be interested to hear from someone else. And even I've heard some people modifying Gore devices, although there's some issue with burning holes in the PTFE. The devices are all different and have different issues and advantages with them. So Alpha is very low profile, and the stents are very far apart. As you can see, that's the graft on the left. So there's a lot of room to put your fenestrations. The TX2 is much easier to get in and out of the device, or out of the sheath, which is the device on the right. But you can see the stents are very close together. It's very difficult to find real estate to put your fenestrations, especially if they're bigger, like 8 millimeters. You kind of have to often cut those stents and bend them out of the way. But it's much easier to repackage. There's no barbs on it, et cetera. So advantages and disadvantages. You need to have a back table. So if anyone is interested in doing PMEG at some point, I'm happy to share my list that is posted in our operating room of what you need. But it's sort of a little mini operative setup, right? You need wire cutters to cut various things. You need casters and forceps and needle drivers to put stitches in. Snares and coils are for reinforcing the fenestrations, which I'll show you so you can actually see them, right? You can't see a hole in a graft on an x-ray. You need to have something metal there. Scissors, eye cautery to make the holes, and I think it's really important to use the low temperature version, which is shorter and easier to handle, but also won't set your graft on fire. And then some way to get it back in with umbilical tape or ties or something. So I thought that for this, since it's how I do it, I will show you how to modify an alpha graft. And again, this probably shouldn't leave this room. So the first thing you got to do is unsheath the graft, and this device specifically has to be unsheathed in the direction that you deploy it in the body because of the directional barbs at the top. So the barbs point downwards, so you can't pull the device out of the back, which is what you do for a TX2 or a Z-Fen. So once you get it out of the device, you can see it's there on the table. You have to remove the proximal barbs because if you're taking it out with the direction of the barbs, you're going to have to put it in against the direction of the barbs. This is a wire cutter, which is the way I used to do it, but I tore up a couple of sheaths trying to get it back in. So actually I use a needle driver flush with the fabric and just kind of twist until they break, and then they're pretty flush usually. Once you've done that, the next thing to do is to take a trigger wire out from the inside. And I think one of the interesting things about doing PMEGs is you actually really get to learn the way the devices are constructed and constrained and packaged really, really well. And you have to, because otherwise you're not going to be doing it right. So when you look inside of this graft, there is an inner cannula, and inside of that inner cannula is a central core where the wire goes, and then there's 3 constraining wires that hold this trifold at the top. So you cut that open with a knife or a pair of scissors, and you fish one of the wires out and pull it all the way out, and then one of the folds of that trifold will pop open. You then take that and repurpose it as a spine going under the stents so that you can constrain around it later. I'll show you how that works too. Next step is to measure and create the fenestrations. When you are measuring for like a Z-Fen or a custom device, really what you have to tell the manufacturer is what distance from the top of the graft and what clock face position that's at. When you're measuring it physically, it's very hard to measure 230, right? So you actually have to calculate an arc length, which is the circumferential length along the graft where the center of your fenestration is going to be. So it takes a little bit of online calculation or some kind of, you need the circumference and that kind of thing, and the number of degrees that correspond to which clock face angle. Figure out where you're going to go. Sometimes you have to frame shift the whole thing up or down if you're in the middle of a stent or something like that. And then you have to reinforce them somehow. So I like to use the double wrapped snare, like a 30, whatever it is, the largest gooseneck snare, because it's gold and you can see it really well. Double wrapping is really just for extra reinforcement, and so you can see it really well. People use all sorts of coils and whatever. It doesn't really matter as long as it's visible. And then I use a running locking CV5 Gore-Tex suture. So then this is where the spine comes in. You've created your fenestrations, you're ready to start sort of repackaging this. And if you've done some Z-Fens, you know that graft is actually constrained to like 20% less diameter so that you can maneuver it in the aorta and twist it if your fenestrations are not lining up. And so that's what this is. So this spine on the back there gets Prolene sutures put on either side, and then you cinch the graft around that spine with 2 sutures that come from either side. At the end of the device, one of the steps is you pull all the wires out the back, which opens these up, and the things pop open and allows it to expand to its full diameter. Once you've got it all constrained, you need to get it back into the sheath. This is a little bit difficult with alpha because it has to go in backwards. So you have this big device that has to get in through that tip of the sheath there, and it can definitely get damaged. If it does get damaged, it can be challenging to get the device introduced safely because there's a step off between the dilator and the sheath tip. So you have to be pretty careful, and especially if you're using directional branches with an alpha, it's very, very difficult to get it back in. So I tend to use this only for fenestrations. You also have to be careful not to twist it, right? So it's easy to put it in and have it kind of corkscrewed on itself, and then when you deploy it, you're very surprised. So again, this is like where these extra risks come in because the manufacturer is very safe about putting it in, and you're kind of shoving it in on the back table. And then make sure it goes all the way in so that the obturator is flush with the front. Make sure not to dislodge the distal trigger wire. I will tell you that is a very painful situation, which happened to me once where I was twisting the graft and it was not attached at the back and the whole thing candy wrappered, and it was very difficult to get open, and it's a very lonely, harrowing feeling when you're looking at an aortic coarctation that you've created. Just a couple of additional things. I mostly do fenestrations. I have incorporated some other things. So antegrade branches, basically you can cut a viabond into about a 2 centimeter segment, sew it on. You need to sew a marker around that also so you can see where it is. When you're measuring for branches, you generally want to be about 3 centimeters above your target, 2 centimeters for the branch, and then 1 centimeter of working room. Fenestrations, you want to measure like right on. Inner branches are a really good technique. So you can see in that center there where the branch is actually sewn on the inside, it obviates this issue or avoids this issue of working room where Dr. Schneider was talking about needing like 25 millimeters at least. So if the branch is on the inside, you kind of get some of the advantages of a downward going branch and more overlap without the need for an external branch. And I generally do those with pre-wires, as you can see. The pre-wires are pre-cannulations of the fenestrations, which generally we'll do from above. So you pass the wires out through the arm, and then you have a sheet that can kind of come down over the top, get into the fenestration, and then all you need to do is get out into the target vessel. Can definitely save some pain of trying to cannulate. Just an example of a typical type case. So this is a very diseased aorta. There's a celiac stent and an occluded SMA, as well as some very diseased renals, and then a type 1A endo leak from a prior graft. This is what just some cuts to show you what we're dealing with. Again, this is pretty typical, and there's not really a solution for this with currently available devices, right? A Z-Fen device probably won't fit above the flow divider. You won't be able to do a bifurcated device, so you're really limited to a PMEG. This is kind of what a PMEG looks like. I didn't go through all the steps because they're very similar to doing a custom device or whatever, but you can see those doubly reinforced fenestrations are very easy to see. This is an alpha that's sealed into the main body. We used a Gore cuff to kind of reinforce the overlap just above the flow divider, and then on the right there you can see the final angio, which this one at least looks very good. So. All right, that's us modifying. You have sterile back table. That's one of our junior faculty, Dr. George, helping me out. And then you can see on the right, this is what kind of looks like in practice. But happy to answer any questions. Thanks.